Okay.
Okay, welcome everyone to our Geriatric Palliative Care Grand Rounds. And it is my pleasure this morning to introduce Gina Campelia, our presenter today. She received her PhD in philosophy at CUNY and is currently part of the Department of Bioethics and Humanities at the University of Washington School of Medicine. Her writing and practice focuses on establishing structures to enable and encourage empathy and facilitating greater recognition of the relational constitution of patient identity and decisional processes. And I stole most of this from her UW bio, but I personally know Gina through her invaluable work as an ethics consultant for UW Medicine's Ethics Consultation Service. And she has helped me navigate many challenging situations and gray areas at Harborview. I've noticed recently that when I attend on medicine or geriatrics and palliative care service, I encounter a number of patients with diminished decisional capacity and no surrogate decision maker. I suspect that we will continue to see an increasing number of these folks, particularly in our aging population and with the epidemic of isolation that many of our older patients face today. So I am very grateful that Gina accepted my invitation to lend her wisdom here today to help give us a framework through an ethics lens on how to approach these challenging situations. I will be helping to moderate and keeping an eye on the chat, and we're going to ask you to use the chat a lot. So this will be a very interactive discussion, and you'll be asked again to enter your thoughts in the chat and participate in some really hopefully exciting polls. So please open up your chat windows, get them ready. I'm stealing a page from Caroline Hurd here, but it would be great to kind of see who we have with us. So feel free to just like warm up your fingers and put in the chat. Just type a couple of quick words to let us know who you are, maybe where you work, what your role is. So we kind of get an idea of who's with us here today. And that way you get ready to participate in our chats and our polls. And again, even though Gina put my name at the top of her presentation, I am moderating today and helping to make sure that I keep an eye on the chat box and run the polls for her. So thank you and welcome, Gina. Oh, and I love it. People are already entering some things here, and we have some fellows and geriatricians at Harborview. Oh, Director of Washington State Hospice and Palliative Care Organization. Amazing. Barb is here with us. Pam Davies, wonderful. Swedish. VA American Lake PACS social worker. This is fantastic.
Yeah, this is great. Good morning, everybody.
We have folks from Portland. Good morning, Jasdeep. Good morning, Kay. Wonderful. Okay, sorry, Gina, take it away.
No, that's
Wow,
all
these
right.
keep
This
rolling
great.
in. This is fantastic. I love
This is
it.
great to see everybody and where you're all coming from. So we're going to talk through some of the basic definitions around informed consent and decision-making capacity and the roles of surrogate decision makers. But we're going to use a case to do all of this, and then we'll maybe move through a bunch of those definitions fairly quickly because they may be review for a lot of you, but please stop us if they're not, or if you have any specific questions around them. And then we'll dig into some of the more nuanced and gritty details of the ethical complexities that arise in these kinds of cases. And so I'll just turn it over quickly to Annie to talk about a case that she had.
This is a case I ran into or several cases that I ran into, all kind of put together. So based on real people, but anonymized for this presentation. So a 72-year-old gentleman with COPD, heart failure with reduced ejection fraction, type 2 diabetes, obstructive sleep apnea, and epilepsy, recently hospitalized for pneumonia and was recovering at a skilled nursing facility with the goal of returning to his DESC housing when he developed a fever and altered mental status and was brought back to the hospital. So he was being managed in the ICU initially for pneumonia, sepsis, and found to have suffered a heart attack. He continued to worsen clinically and had prolonged periods of apnea, so just not breathing, lasting up to 70 seconds with desaturations into the 50s. He also had worsening mental status and was no longer speaking intelligibly. So they obtained a CAT scan of his head, which reviewed no acute abnormality. So this patient was found to have a palliative care social worker involved in his care who had known him previously from interactions and care. And our palliative care social worker said that they believed the patient would not want heroic measures, but would have wanted a time-limited stay in the intensive care unit for any reversible causes. So thus the patient was made DNR, DNI, so do not resuscitate, do not intubate. And the intensive care unit team felt that the patient might benefit from some diuresis to optimize his lung function, but despite aggressive attempts at getting some fluid off of his lungs, his clinical status just was not improving. So they actually made a decision to transition him to comfort-focused care. He was admitted to the medicine service, the medicine acute care service on comfort-focused care, and he had been started on a hydromorphone drip due to some persistent agitation, some Haldol as needed, and so some lorazepam as needed, and a scopolamine patch. Okay, any initial thoughts or reactions to what happened there? And feel free to share them with us in the chat. What do you think? Just initial reactions to what happened. So I see, who is his surrogate? Question mark, yes. No DPOA paperwork? No, none. It's interesting the palliative care social work is his closest surrogate. Why benzos? Anticholinergics can worsen delirium. So many medications that cause delirium. Yeah, these are some great reactions. Yes.
Yeah, these are great questions, and I wonder if maybe we should, as others maybe throw in some more chats, launch that first poll. So this patient's code status was changed to DNR, DNI. Is that ethically permissible just based on intuition or what you know?
Okay, so we're seeing some really great results coming in, and I love our high rate of participation. So yeah. Great job, everyone. Just so you know, it's anonymous. The poll is anonymous. Excellent. So I'm gonna give it, I think we've gotten all the answers we're gonna get, so I'm gonna end the poll here, and you can kind of see how we sorted out there. Okay.
Yeah, so really mixed, which is understandable given, you don't have a ton of information about how this came to be. We have all these questions about surrogates and who's actually responsible for surrogate decision making, which is great. And so so the mixed response is understandable, and we'll come back to this question again. So next poll question is it ethically permissible, given everything you know so far about the case, to transition this patient to comfort measures and only? And again, based on intuition, what you know so far about the case, just pop in some responses. Okay, so again, mixed, pretty evenly split between yes and no, and a lot of folks feeling uncertain, which I think is reasonable given given what we know. And this is a really complicated territory, which is why we're talking about it today. So the next question I have before digging in is, what are some of the next steps you might take? And if this was your patient, you were involved in this patient's care in some way, what are some of the next steps you might take to kind of gather more information, or what kinds of questions might you ask if it's anything beyond what you've already asked in the chat?
Okay, I see a lot. As social work, try to find the legal next of kin. Lots of legal next of kin, DPOA, social work, yep. Okay. Healthcare social work was involved in his care previously. Does he have a living will or pulse? Don't reach out to DESC since it sounds like their team might know him. Find someone who knows them and can weigh in on what they're like and their values. Bring in moral question to the mix.
Great. Great. So, assuming this was not done at a risk-averse hospital, yeah. So I think that there was some confusion in this, and I mean there is confusion in these cases, and there's so many sometimes conflicting legal obligations, ethical obligations, and then sometimes there's a lot of uncertainty, though not zero information about what the patient would have wanted. And so either there's uncertainty because the patient has maybe conflicting preferences that they're articulating, or there's uncertainty because they can't state preferences, but we have somebody who knows them well and is able to kind of speak to their choices in the past, or we have documented history of choices the patients have made or statements they've made in the past, and we're trying to apply that to a time now when the patient can't speak for themselves. And so it can be really, really confusing. So just want to take a step back and walk quickly through some definitions. Stop me if you need me to clarify something further, and then we'll dig in a little bit more. So just backing way up, in terms of making decisions about patients' care, we ideally are looking for informed consent, and that's both from an ethical and a legal perspective. Informed consent is not just whether or not the patient is willing to accept, but also have they been given appropriate information? Are they competent, or do they have decision-making capacity to decide? Does the patient understand the information? Not just have they been given it, but have they actually demonstrated understanding about it? Are they making a decision about the treatment voluntarily? And then that specific consent to the treatment. Informed consent, as it's maybe already obvious from the definition, depends on decision-making capacity. We assess decision-making capacity based on Applebaum's criteria, which first are communicated choice, then understand the relevant information, appreciate the situation, and reason about treatment options. So in this case, we were missing a lot of this, right? Though we might have had some choices in the past in terms of decision-making capacity here in the moment, what we're looking for is, can the patient communicate a choice right now? Have they demonstrated understanding of the information? And that's just their specific their specific medical context, their what the treatment options are, those sorts of things. And then the appreciation of the consequences is what might happen if you go down different pathways for treatment, and then reason about the treatment options, meaning the patient can express reasons for choosing one option over another or refusing different options. And those reasons may not be reasons we agree with, but they're reasons nonetheless. One thing to keep in mind about decision-making capacity is that there are several myths that kind of float around about decision-making capacity. I've highlighted a couple here. This is a great kind of fast article to take a look at that runs through a bunch of myths about decision-making capacity. Some of the key ones that might come into a case like this is I think primarily that lack of decision-making capacity is a permanent condition, as some of you noted, I think, in some of your questions. And then also only mental health experts can assess decision-making capacity is another one that maybe not immediately but later on in this case will become relevant. Okay, so the obligations of surrogate decision makers, right? A lot of you said, where's the legal next of kin? Who is there a surrogate decision maker? And so a surrogate decision maker can be a legal surrogate decision maker, can be any number of people, and how we define who the surrogate decision maker is legally depends on the state. So in Washington state, we have a hierarchical system in which a durable power of attorney or a legal guardian is at the top, and then comes partner and so on. And then it goes down a list of several individuals who the patient is related to in some way, or who knows the patient, who could speak on the behalf of the patient if they don't have decision-making capacity, as in this case. If you have a surrogate decision maker, which we did not in this case, a patient's clinician cannot act as a legal surrogate decision maker unless they go through a long process of becoming a legal guardian. It's rare that really happens, and it can be a really prolonged process. And sometimes I've seen PCPs become a legal guardian for a patient in rare, very rare circumstances, but you have to go through this whole legal process to do that. Really, you need a legal next of kin or a durable power of attorney, and that person is supposed to primarily use substitute judgment. So what would the patient have wanted if they were here and could speak for themselves? And you're supposed to base those decisions off of maybe statements the patient has made in the past that you can recall, or something like that. And then best interest standard, what would be in the patient's best interest, ideally from the patient's perspective, but we don't always have the patient's perspective. And so what would generally be in a patient's best interest is kind of a secondary question you can ask there. Okay, so how do we pull all this together? So in a case like this, where you don't have a legal surrogate, at least not immediately, one isn't obvious. We can say up front that no clinician is obligated to provide medical therapies or interventions that are not medically beneficial. So if it could be stated, if there was consensus that different interventions in this case, such as resuscitation and intubation, would not offer any medical benefit, then no clinician is obligated to provide that therapy, that intervention. And then a second key point in these end-of-life decisions is that patients and legal surrogates have a right to refuse, withhold, withdraw medical therapies or interventions, regardless, as long as the patient has decision-making capacity. It's their legal and ethical right to refuse any therapies or interventions, even if they're in the best interest of the patient from a medical point of view. And then lastly, efforts should be made to support patient choices and reduce harm. And I think this is where a lot of your questions were ending up in thinking about that part one of the case. Are there ways we can find a legal surrogate who can speak to what would be beneficial or harmful from this patient's perspective, what they would have wanted? And are there things we can do in this case to actually regain autonomous decision-making for this patient? And so those are some key questions to be had. Is there any way we can get at what the patient would have wanted, either from a legal surrogate or from the patient themselves. Is there anything we can do to get there before we make these big decisions about changing the patient's code status, transitioning to comfort measures only? And if we can't get there, then the bigger question, then the remaining question is, how do we reduce harm in a holistic sense? So not just in a medical sense, but in a more holistic sense, considering everything we might know about the patient. And that's where, if we didn't find a legal surrogate decision maker in this case, we might be able to rely on some folks like the social worker, like other folks who have known the patient, who we can reach out to, who might be able to help us understand some things about what the patient would have wanted. And that might ultimately help if we need to have a legal guardian. And in this case, at the end of the day, that might help also make the legal guardian make their decisions. So another thing to consider here is, and this goes hand in hand with, in the previous slide, we talked about no clinician is obligated to provide medical therapies that are not medically beneficial. There are different ways to think about what it means for something to be not medically beneficial, and there can be a lot of disagreement around that. So there's both quantitative in terms of days, months, years, really broadly in terms of longevity, but then also qualitative. And so for changing the patient's code status, if it's futile and in the quantitative sense, if people are in agreement there, meaning that the intervention has a very low probability of producing the desired benefit, i.e. restoring a rhythm, for instance, then an argument can be made not to offer the intervention, right? Not to provide the treatment, because there's no obligation to provide interventions that are not medically beneficial or medically futile. And often your institution will have a policy about this and have some specific language around defining what constitutes medically non-beneficial or medically futile treatment. When talking with patients and families, it's not ideal to use the term futility, because of course it can feel like you're saying that care more broadly is futile, or that the patient's life is futile, or something along those lines. And so talking about the medical intervention not having medical benefit in specific ways is it can be a helpful way to go with those conversations with patients and families. And so sometimes people also talk about medically inappropriate treatment. And this is where, this is just a different way of talking about futility, where it has a broader understanding here, where the treatment might offer no reasonable expectation of achieving the goals of care, for instance. So if the goals of care are for the patient to discharge home, and any treatment we can provide is not going to get there, then it might constitute medically inappropriate treatment. Or if the treatment is going to cause or likely to cause suffering, unnecessary pain, or loss of dignity. These are other reasons why we might constitute a treatment medically inappropriate. But of course, these are big gray areas and can be really hard to define sometimes. Sometimes quantitative futility, if we can actually get there, there will be consensus around it. But I think it's really rare that we're actually in a place where it's actually physiologically or quantitatively futile to provide an intervention, i.e. the intervention is just not going to do, even if you try, what it's supposed to do. There's this much bigger realm of how do we think about this qualitative sense of futility or qualitative sense of medically non-beneficial. And that depends so much on what the patient's goals of care are, what the goals of the treatment are, and there's usually a lot of risk of harm, but also possible benefit. And I saw a comment, from Laura Bach. Yeah, I think the struggle between the quantitative versus qualitative futility in these situations is real. It can be where we really get hung up, I think. Any other questions about these definitions? For folks who are at UW, these definitions are actually in a policy we have on withdrawing and withholding life-sustaining medical interventions. And that policy is really a process-oriented policy that helps you walk through how to handle withdrawing and withholding different medical treatments. Okay. So with all of this in mind, in this case, what we now know, we have no surrogate decision maker. We might have some questions around whether or not resuscitation, intubation, or other interventions can count as medically futile or inappropriate treatment. And we have a patient who can't currently articulate their own preferences or choices, all right? And so, so with all of that in mind, let's ask those questions again that we asked at the beginning. Is it ethically permissible to change the patient's code status to DNR or DNI?
Can you quickly review the mental status again?
Yeah. Anna, you want to? Go ahead.
Yes, I think where we left off is he's now on the acute care floor or acute care service, and our patient is on a hydromorphone drip for agitation. So he's still not able to communicate a choice, right? And he's still delirious, still pretty confused, and not able to really talk to you. And Gina, I kind of coupled the next poll question with this one just to kind of see and do a temperature check of where we landed.
Yeah, that's great.
Okay, so I think I'm going to end the poll here. That's kind of where we sorted out.
Okay. So several people some changed their answers and several people didn't. Great. And it seems like there's still a fair amount of uncertainty. So let's keep going because I think we haven't really fully answered these questions yet. Okay, so at this point, so let me back up for a second. At this point, if it were determined that resuscitation and intubation were not medically appropriate, were medically non-beneficial, or were medically futile, it could be reasonable to change the patient's code status. Without a surrogate decision maker to make, or the patient to consent to decisions to change code status and or transition to comfort measures only, it can be really difficult, at least legally, to make those decisions without a surrogate decision maker. And ideally, in a case like this, you would see if at the very minimum you could, before you made these decisions, if you could find that surrogate decision maker, or if you could get the patient to a place where they could make decisions for themselves. And so you would err not having any sort of advance directive from the patient or a surrogate decision maker or patient capacity. You would err on the side of longevity and until you had maximized all your efforts to find a surrogate decision maker or get the patient to a place where they could make the decision on their own. And that's based on respect for autonomy, primarily. It's also based on reduction of harm. So while it might be arguable in a case like this, that a transition to comfort measures only may very well be what the patient would have wanted. And you might hear several voices of people who knew the patient who say, I really don't think he would have wanted this. If he's not going to be able to get home, we shouldn't be doing this. You might also hear some people saying, well, maybe we could get him home. And so where there's that uncertainty, you're really going to err on the side of, let's see what we can do to help him recover, at least focus on longevity until we know otherwise, until we know for sure otherwise that the patient would have wanted otherwise, or until the patient or a surrogate decision maker makes that decision. Okay, now again, that comes into tension with if any of those therapies are physiologically futile, right? They're not going to reach the desired benefit, and there's no chance that they will. There's no obligation to provide them. Absolutely. And you could make that argument without a surrogate decision maker, but I think it's rare, especially in this context, we couldn't really argue that, is my sense. Yeah, and I'm noticing the comments in the chat. Yeah, and most institutions, it's difficult. There's policy, legal policy that prevents you from changing code status order unless there's at least an advance directive or post, or you have the patient or surrogate decision maker to make that decision.
Yeah, and Gina, I think you're probably seeing some of the great comments by Lisa and David, but Lisa says it's often hard to keep your own preferences about life out of qualitative futility determinations. And I think you probably see that very frequently in the ethics consultations you receive. And David says it's hard to separate this discussion from our obligations to historically marginalized groups. And I think that too plays quite a big role in some of the discussions and ethics consultations and thoughts around how we think about these patients.
Yeah, exactly. And that's a really important check on the process too. Part of the reason we err on the side of life sustaining is a protection motivation, right? It's to protect vulnerable populations, to make sure that we're not making biased decisions about whose life is worthwhile or not worthwhile. In a setting where that person can't speak for themselves or they don't have an advocate who can speak for them. So thanks so much for those comments. Okay, we're going to keep talking about this, and we're going to just dive even deeper into the nuances here. So, and you want to dig into part 2?
Yeah, so this case continues. So palliative care was consulted to help transition the patient off of the hydromorphone drip and onto medications he could potentially discharge back to his skilled nursing facility on, but with comfort-focused care. So we weren't consulted for goals of care. We were consulted to help transition this patient to more skilled nursing friendly meds. And given that the patient is previously opioid naive, we recommended stopping the hydromorphone drip. He woke up, so his mental status improved off of the drip, and upon our visit, he is now oriented to himself and to Harborview Hospital. His language is coherent. He's now speaking in full sentences. He initially did not remember why he was in the hospital and had poor insight into his functional limitations. So he was needing 2-person maximum assist to just even get out of bed or sit up to get to the edge of the bed. And he has a very poor short-term memory. So he doesn't remember nursing telling him, please use the call light, even just a few minutes before we walked into the room. So he is now awake, alert, and occasionally or intermittently refusing his lab draws, refusing his medications. And at night, he has been noted in the nursing notes to have agitation. So he pulls out his IVs. He tries to get out of bed without help. He doesn't remember to use his call light. He appears to retain the information that he's in the hospital for pneumonia. And when the palliative care team asks about his goals and values, he's able to share that he wants to get better. So he can return home and drink his coffee, lie in bed, and listen to rock and roll. So when asked if he would want treatments, such as the medications and lab draws for his medical condition, he states no. He is not clearly able to explain what the possible consequences of that choice might be. So given the patient's poor insight into his functional deficits and fall risks, he tends to get up out of bed at night particularly and attempts to go to the bathroom independently. So staff notes suggest that he is not redirectable. He gets agitated when they try to redirect him, and requires restraints for fall prevention and safety. He's also, again, pulled out several IVs, and now he's being restrained and remains in soft restraints overnight and also during large parts of the day, especially in the middle of our staffing shortage.
Okay, so now we're deeply entrenched in some ethical questions, and they've shifted a little bit. One might still ask, or at least revisit at this point. So we know in part one, his code status was actually changed, though inappropriately so, right, without a surrogate decision maker or at the patient's own attestation. So we might revisit: is it permissible to change this patient's code status, or keep it as DNR, DNI, and also we're already in the process of revisiting the transition to comfort measures only. So let's talk, is it ethically permissible to keep this patient's code status, DNR or DNI, at this point?
Great job, everyone. I have a lot of results rolling in, so I'm going to give it a couple more seconds. Okay, and in the interest of time, I'm going to end the poll there. And that's where we landed.
Okay, so now we've kind of shifted, it seems like, over to, as we're making more efforts to talk with the patient and support, these efforts are in part trying to support his decision-making capacity. So giving him some time and whatever other supports he may need to move in the direction of having conversations around what he would want in terms of his care. The majority is moving towards no. And I think that at this point, it especially given that the first decision to change the code status was not based on what the patient would have wanted necessarily, or what or a surrogate decision maker has chosen, it would be reasonable to change the code status at this point and revisit with the patient before making the code status DNR or DNI, or potentially transitioning to comfort focused care. Now, of course, I think at this point, what the real ethical question is, I'm going to just skip that one for now, the second question. How, at this point, when ethics often gets called in at this point in the process of this case, and the kind of question we end up asking is, how should clinicians balance the patient's goals, seemingly to get better, to go home, to do the things that he wants to do, with in the moment preferences against medications and lab draws? And this is in the context of at least diminished capacity. So there's not necessarily no capacity to make, it's not that the patient lacks all the dimensions of decision-making capacity, because he can at least articulate a preference here, but he has not demonstrated much appreciation of the consequences, understanding of his medical condition, and maybe sometimes, though not reliably, articulates reasons, is what I get from this case. So he's arguably does not have decision-making capacity, at minimally is diminished decision-making capacity. And so in that setting, we're trying to balance those goals, those stated goals to get, to quote, get better, with those in the moment preferences. And I'd love to hear, you know, in the chat, and there's already been a couple of ideas, but what would be your next steps to balance those two conflicting obligations?
And there's been a number of really wonderful comments that the patient is likely delirious. And I think the follow-up question to that is, then what do you do, right? Because he's still communicating some choices and values and goals, but what do you do when he's delirious and communicating those things to you? And poor Angela says, this is my world, dementia. We have to tailor plan of care to incorporate daily plans with big goals, get him to the sniff, paternalism where he can lie in bed and listen to his rock and roll. So goal concordant care there. And Lise says, it sounds like a comprehensive review for delirium risk factors with consolidation of care. So definitely working on the delirium and things that we can do to try to prevent or minimize the delirium. Another great comment, optimize medications, reduce delirium. So we're starting to work on how can we optimize patient and start kind of getting him to a place where he might have better capacity.
Good. These comments are fantastic, and you're really getting at, you know, how do we walk that middle line, right? It's often the case that patients make choices that seem in contradiction, right? But what they're really doing, whether they're choices that are coming from a place of decision-making capacity, right, autonomous choices, or whether they're stating preferences in the context of diminished decision-making capacity, many patients will balance longevity with or quantity of life with quality of life. And so while he may be saying, he may have this goal to go home, of course, but also may make in the moment at least stated preferences, if not actual choices, autonomous choices about what's in his comfort. And that happens all the time. And so how do we walk that middle line where we're not transitioning fully to comfort focused care, but we're also not fully on that longevity track where we're doing all interventions necessary to promote longevity? And that can be a really hard place to be in. And a lot of the comments are making great suggestions about how do we walk that middle line? How do we both be respectful of the patient in a broad sense? So maybe this patient doesn't have autonomy to make decisions or make choices, but they can state preferences. And there are different ways in which we could be disrespectful to the person as a person. Not just whether or not we're respecting their autonomous choices. And so some of the key things that we think about in ethics, one of the comments I already noted talked about assent versus consent. So most likely this is not a patient who can consent to complex medical treatment or provide autonomous refusal, but they can assent. I mean, assent is different from consent insofar as it doesn't need to come from a place of having decision-making capacity, but it can come from a place of whether something's voluntary or not voluntary on the patient's part, right? And so we can seek assent, as somebody said in the chat, wherever possible, and we may make a decision based on beneficence and non-maleficence, so benefiting the patient and reducing harm to the patient, to not compel interventions, different interventions, so such as lab draws, or maybe certain medications, or maybe minimizing vital checks and those sorts of things, right? So those might be offered every day, but then when the patient refuses, we may respect those refuses. That's not respect for autonomy, but it is respectfulness, right? So because the patient doesn't have autonomy, we can't respect autonomy, but we can be respectful of those preferences, even if they're not coming from a place of decision-making capacity and autonomy. It's also helpful to differentiate sometimes patient preferences, wishes, and choices. So I've already talked about that difference between preferences and choices. Patients can articulate preferences without them actually being choices. Choices, the word technically has to do with being capable of decision making, right? Having that autonomy to choose a path, using reasoning, understanding the consequences, etc. Preferences can be stated, but they may not come from a place of understanding what the risks and benefits are. And then wishes are sometimes things we hope for that might not be possible. So a patient might wish to go home, but that may never be safe or possible for the patient. Or the patient might wish to live longer than their medical condition allows, or right? So a wish is something that we can't even affect, but we may wish, we often wish for things. I see a hand up, Angela.
Oh yeah, you just said something there that I guess confused me. You said it wasn't respecting autonomy to let him refuse a blood draw. To me, that's the ultimate respect of autonomy, to let him refuse a blood draw. So I guess I was confused by that. I guess there's like different levels of autonomy. Like, I know, like, it's your body. I'm not gonna, if I touch you and you say no, and I keep touching you, I'm committing assault on your body.
Yeah, that's
like
a really good question and really complicated. So, so the principle of respectfulness is this kind of big, broad principle. And part of it is respecting a person, right? Maybe respecting their body, respecting their dignity, respecting their humanity. And we might do that in all sorts of ways, or just be disrespectful in all sorts of ways. Autonomy is a very specific concept that has to do with whether or not you are capable of choosing your path in life using reasoned and rational judgment, right? There's this big gray area in between. And so I'm going to talk about some arguments to kind of expand how we think about autonomy in a minute. But technically and kind of legally, autonomy and decision-making capacity kind of go together. And there's this history of thinking of it as when you're able to make a reasoned, rational judgment. So you're actually able to make a choice based on reasons, understanding of what's going on. You have that right to choose your pathway in your life. You might state preferences that don't come from a place of autonomy, in that sense, meaning the capacity to make a choice using reason and rational kind of reflection and understanding. So a good example is children, right? So young children don't have the capacity to kind of understand risks and consequences ostensibly like adults do. They are not thought of as having decision-making capacity. That doesn't mean they don't have preferences, right? They might not want a shot, for instance, but we can reasonably override those preferences sometimes in the best interest of the child, while at the same time being as respectful and reducing as much harm as possible, right? So you might still give a child a shot against their stated objections, but you do that as respectfully as possible because they're humans, regardless of whether or not they're capable of making a reasoned decision for themselves. And so it's really, I think that notion of what constitutes autonomy has a somewhat narrow technical understanding, and that relies on being able to reason and make rational decisions. But there are ways to think about it in a broader sense too. So you could think about bodily autonomy, for instance, is I think what you were getting at, Angela, which is what we could allow a patient like this, or be respectful of in a sense, is at minimally their dignity, if not their ability to guide the pathway of their care in some way. And that's not because they have the autonomy to make decisions in that technical sense. It's because we're giving them this, or we're respecting these preferences that they're stating, though they might not be preferences that come from a place of decision-making capacity. So that's really, it's a really complicated piece here. And so when I tend to talk about that in an ethics note, I will say the patient does not have decision-making capacity, but they can articulate these preferences. And what we have to do is minimize harm and be as respectful as possible of those preferences, right? And so we may sometimes compel, because the patient doesn't have capacity, because the harm is too great if we don't, right? Or we're balancing different kinds of harms. And we may sometimes not compel, but it gets confusing if you say, well, we're not compelling because we're respecting autonomy. We're not compelling because the balance of harm and benefit, the balance of disrespectfulness and respectfulness more broadly is what we're doing, not because the patient chooses otherwise. Whereas if a patient had decision-making capacity, we would never be justified in overriding their autonomous refusals. Does that make sense? Is that helpful in terms of clarifying that? Any other questions about that? Because I think it's really, really complicated. Okay. And then, so some other things that go along here with this are, of course, the surrogate decision maker preferences, wishes, and choices. They also can have preferences versus wishes versus choices. They might wish something for the patient that's not possible. And then we're talking about benefit and harm. We're talking about relationship building. How can we build trust with the patient? But also, you know, I think a lot of people talk about non-abandonment, right? So especially for patients who don't have families or friends at bedside or other advocates speaking on their behalf, how can we build the relationships that that support that patient in a sense that are justice-based, right? We're trying to make sure that a patient who doesn't have advocates at the bedside has some advocates in us, but also maybe forming those relationships, sitting down for longer periods of time with a patient like this, you might get a better sense. You might be able to support autonomous decision-making in more ways. And then there's some other concepts we think about in cases like this, like asking versus telling. So does it make a difference for the patient if you're asking them whether or not they want a particular treatment versus saying, okay, it's time for X intervention or X therapy, and how do they respond? Do they assent to one but refuse the other? And what does that mean in terms of whether we're being respectful or not? I think that's a really challenging thing to consider. And then code status versus withholding and withdrawing is also something we'll tend to differentiate. So sometimes it can be reasonable to change the patient's code status, but not withhold or withdraw other interventions. And so that's a place where sometimes what's legal and what's ethical can come apart too. So I think legally there are more hurdles to withholding and withdrawing life-sustaining interventions than there might be to changing the patient's code status. That also depends on the medical context. But sometimes what's ethical and what's legal can come apart. So for instance, in this case, if we continue to have no surrogate, we built information that the patient was regularly refusing, you know, all interventions, though not with decision-making capacity. And we built some history of knowledge that the patient never would have wanted life-sustaining interventions based on what people are telling us, though no surrogate decision maker to make that decision. And there might be ethical justification for transitioning, for changing the patient's code status, withholding and withdrawing interventions, but we may not be able to do that legally without a surrogate decision maker or a legal guardian, right? And so that usually what's legal and what's ethical lines up, but there are cases where I've been in ethics meetings where everybody thinks that there's no way, that we're basically causing more suffering by continuing life-sustaining interventions for a patient, but we have no ability to say they're not promoting longevity. And that can get us into a tricky place legally. And we basically end up waiting for a legal surrogate decision maker, like a legal guardian, which can take a long time, and a lot of moral distress can come from that, because it feels like there's this obstacle, this legal obstacle to having a legal surrogate to make the decision. And that's a really tricky place to be in too. Angela, did you have another question?
No, I probably just forgot to put the hand down.
Okay, just checking. All right, so we only have a few minutes left. One last thing, I'm going to share these slides so you can go through them. The remaining slides kind of talk about what are the questions we ask from the different ethical approaches, and so some of the key ones we use in this case are respectfulness and respect for autonomy. I put those together. Beneficence and non-maleficence. Justice is crucial here. Both justice is fairness, justice is equity, but also transformative justice. And then trust, empathy, and care is another kind of framework that I use. But one more thing I wanted to mention, because it fit with your question, Angela, was there is some work out there to expand our understanding of what patients should be capable of refusing in the realm of life-sustaining treatments. And so when patients don't fit, as in this case, that mold of what constitutes decision-making capacity, there might be other ways in which we think of their refusals as really legitimate and should be respected, right? Even though they don't technically have what we legally think of as decision-making capacity. And so and these happen all the time. So there are burdens-based refusals. Sometimes patients make informed decisions to refuse possible medical interventions if they have an overriding objection to the burdens those interventions pose, right? So this happens all the time. Patients refuse interventions that are too burdensome, too uncomfortable, cause too much pain, right? And they may make some comparative judgments here that they're not able to articulate. It may not be obvious that they're fully informed, but it may be reasonable to respect those refusals, as in this case, right? Respecting that patient's refusals of lab draws or something like that, right? It's a burdens-based refusal, potentially, that we're respecting. Likewise, goals-based refusals, sometimes patients have long-term commitment to certain goals, or right, consistent preferences over time, that even if we can't gather from them or from a loved one or someone who knows them well, it's in the chart, right? That they've consistently refused certain interventions over years, potentially. And so we might reasonably say that a patient is committed to the goal of no treatment or not treatment over time and has regularly refused all medical interventions. And so to treat them over these in the moment refusals would be really inconsistent with their long trajectory of preferences and choices. And so that might be another reason. Now this gets complicated because, again, these are new ideas in ethics to think about, how we think about respecting patients' decisions. But I just wanted to put it out there because I think we often end up in these circumstances. And exactly, as is one key piece here, and why I always include justice as a key feature of the ethical approach, is we have to think about how different biases, different forms of oppression might be affecting any of these judgments, right? Any judgments about what constitutes a burden, any judgment about whether a patient does or does not have decision-making capacity, and so on. So I really appreciate that comment, and it wasn't discussed already. Thank you. Okay, we're out of time already. Thanks so much. I put some references here too that I'll share these slides, but if there's any last questions, I know we only have a minute left, just put them in the chat or shout them out.
Wayne has a question.
Yeah. Hi.
Change your mind, Wayne?
Thanks, Gina and Annie. Good, excellent job. Really enjoyed this. There's two items that came to my mind as the discussion came along. And Eric and Katie can chime in as trauma surgeons, but they still have been wanting some kind of emergency process for determining resuscitation status in people kind of like this patient, but maybe even worse off, where there is simply no surrogate and the patient appears to be dying. Some administrative mechanism to determine code status. The other thing that occurred to me is about a week and a half ago, we came pretty darn close to being under crisis standards of care, where we would have decided for this patient, you are no code. We're deciding for you. We don't really care what you think. And wondered if we shouldn't be ready for crisis standards of care with such consensus mechanisms to just basically determine people's code status without their input.
Yeah, that's a huge question. If we were to really enter crisis standard of care, those decisions should be made by committee, by the triage committee, ostensibly. But of course, crisis is challenging, and there may be so many similar decisions to be made that it may overwhelm even a specified committee to make those decisions. So that gets really, really difficult, and it really runs up against those justice problems, right? Are there discriminatory judgments being made into whose code status should be changed and who shouldn't? And that might in part depend on, is there an advocate at bedside to say, no, this patient, my loved one would have wanted this or not? And that can be a huge vulnerability in a patient like the case we talked about. So I think that is a really big question, and there may be reasons. This talk was assuming not crisis standards of care, but of course, different decisions might be made in crisis. And I think there's ongoing conversations about how those decisions would be made, especially with equity in mind. Well, thanks so much, everybody. I'm always available. I'm going to pop my email into the chat. I'm always available to talk. And so please don't hesitate to reach out. I really appreciate all the participation. This was we didn't even get to all the slides. This was a great discussion.
Thank you everyone for joining us, and thank you, Gina, for this really fantastic discussion today. Happy Friday, everyone.
Bye, everybody.